to travel, journey, voyage, expedition, tour, pilgrimage, safari, odyssey, to boldly go where no one has gone before. Welcome to our podcast, Travel Unravelled, an ISTM podcast sponsored by the International Society of Travel Medicine and IAMAT, the International Association for Medical Assistance to Travelers. Welcome back to Travel Unravelled. This is our first episode of season 2. We made it back. It is so nice to see everyone back again. We have Dr. Sarah McGuinness from Australia. Hi Sarah, everyone. How are you?
Very well, thanks.
You've just come back from your summertime vacation there, yes?
Yeah, it seems like a long time ago now, but got some beach time, which was nice.
Oh, excellent, excellent. And then we have Dr. Albie de Frey joining us from South Africa. Albie, how are you?
Well, I'm in dark Africa because since we've had Sarah join us in order to juggle time zones around, I'm the only one that's about to go to bed.
It's still dark here too, Albie, because it's 5:30 in the morning.
Right, winter's creeping in there. And Albie, what have you been up to for the last little while?
Actually, I've been on a very interesting little trip quickly down to a part of the escarpment on the way down to Kruger with some Dutch friends, and after that we did a quick trip on the garden route between Storms River and Cape Town, the sort of traditional tourist route, and that was great fun. Cape Town's good for a holiday.
Oh, that sounds beautiful. And then we've got Dr. Anne McCarthy. I know Dr. Anne McCarthy is getting busy for the upcoming CISTM, the International Society of Travel Medicine meeting. Anne, how are you?
I'm very good, thank you. Just got back from a meeting where we finished off the program for ISTM, which is very exciting. So looking forward to the meeting in New Orleans.
We've got lots of feedback coming back from our listeners. They loved season 1, and we're going to have many more exciting episodes for them in season 2. So I'm quite excited, and it's nice to see everybody back here again. So kicking off today, we're going to be talking about some of the conventional wisdom around vaccine and the category of vaccine that we tend to call travel vaccines. But what we're doing today is, in fact, we're making the case for reframing the conversation around travel medicine and vaccines, and to look at maybe why we should talk about how every vaccine should be a travel vaccine in today's interconnected world. So the context for today's episode is really the latest global outbreaks that I'm sure everyone's been hearing about, and looking at the context of why maybe vaccine gaps are fueling the spread of these preventable diseases and what every traveler needs to know in regards to them. So specifically, today we're going to talk about 4 major diseases, which can be serious, but also can be prevented by vaccination. These are measles, Mpox, influenza, and polio.
Aisha, you mentioned them, and immediately it jumps up that measles, influenza, and polio are considered to be traditional childhood vaccines, or influenza for children and the elderly. And we never mentioned them in the context of travel vaccines per se. I've been on occasion asked to speak to public health nurses, doctors sometimes, as a travel doctor. And when I walk into the room, there's this atmosphere that says, oh, you're one of those clinics that gives vaccines to the rich going on safaris. And then, to say to them, but really we're on the same side, because public health and travel health are intimately connected. And if I don't know what's going on in public health, I can't advise my travelers. And my travelers sometimes comes back with diseases, and they become sentinels for what's going on in public health in a particular part of the world. And so we're really all on the same side. And the idea that there are childhood vaccines for the infirm, and then there's travel vaccines for the rich and famous has just become very outdated, in particular in the last couple of years, where we've seen a resurgence of things like measles, where we're really not getting rid of polio, and where Mpox, that has always just been something affecting all those people in the deep, dark depths of Africa, has come to the fore because it traveled.
Absolutely.
Yeah, I think there's also a blurred line between what is travel medicine and what's global health. And so when we see a traveller, it's not just about protecting the individual, we're also thinking about protecting the people around them. And so we need to prevent our travellers from exporting diseases to other places and starting outbreaks, but we're also protecting our community when the traveller returns. And so when we use that that public health lens, really every vaccine becomes a travel vaccine.
Absolutely. I remember the stories of at the start of the COVID outbreak, but that rich family that came back from Italy and brought that new virus from Italy to South Africa. And, it was just the start of something that nobody had a grasp of, but it was the big pandemic that we were waiting for. And it was brought back here by travelers from Italy.
It's a perfect example how it wasn't just a travel vaccination that was needed. It was a broader vaccine for everybody that was needed to build the protection to kind of move forward.
For us, it was actually rich people on ski holidays bringing COVID back from the US.
All right, we're going to start with measles. And measles is actually part of the childhood primary vaccine series, but it's a wonderful example of why vaccines are really crucial. It's highly contagious and it spreads through the air. So it will actually pick off the people that aren't immune and can make them very sick. The illness includes things like runny nose and cough and red eyes and rash in the mouth as well as rash on the skin, but sometimes can lead to complications that occasionally lead to death. And it, like I said, it really picks off those that aren't immune. You can actually catch it from somebody who's been in a room, even if they've left a few minutes before you. So the safest way to be protected against it is really to be vaccinated.
Anne actually just got back last night from Peru, and coming through customs at the Canadian airport, they had screens with all these symptoms and all these infographics about measles and concerns about people who may be presenting with symptoms. It's the first time I've seen it on so many screens in the airport. So what's going on right now in regards to that?
There's so many outbreaks that are going on in Europe, for example. There's been a surge of cases, and the highest cases in the last 25 years. And WHO attributes that to the poor vaccine rates that we're seeing. UNICEF is concerned as well about the poor vaccine rates and seeing more cases than they've seen since the 1990s. We know that young children are at risk. They account for almost half of the cases, 40% of the cases. The US is not immune. There's an outbreak that's ongoing in Texas and New Mexico that really has taken off since the beginning of this year, with 259 cases, 34 hospitalizations, and now 3 deaths. 2 in young children, 1 school age, 1 infant, and 1 in an adult, all related to not being vaccinated.
And I believe that the infant that was in Houston, I believe, reading the news, was recently exposed during international travel as well.
Yes, very scary, right? The airplanes, airports, just hanging out with people who aren't vaccinated who might have disease. There's lots of potential risk.
In Australia too, we've been seeing measles cases. So they've recently been reported in Victoria and New South Wales, and Australia has eliminated measles. So these are cases that get imported by travellers, mainly from Southeast Asia, very popular travel destinations for our travellers, where there are ongoing measles outbreaks. And, we're seeing these travellers come back with measles and then expose others in the community. And for those who are unvaccinated or under-vaccinated, they're at much higher risk of getting measles. And there have been places where people have been exposed, like hospitals and clinics and shopping centres. So really, our health authorities are prompting everyone to check that they're vaccinated and get updated. Like Anne said, this is a highly contagious virus. It's one of the most contagious diseases we know of, and it's spread via respiratory droplets. So coughing, sneezing, shouting, singing, all of those things can spread the disease. And it can linger in the air. These little tiny measles particles can remain suspended in the air after someone leaves the room for even up to 2 hours. So you can imagine if a measles case is walking through a hospital emergency department or a shopping centre, that virus can remain in the air and people can breathe it in, even if they had no idea that they had contact with that person, because they might have already left the space. So places like crowded airports and airplanes, public transport can be ideal conditions for transmission. And so travellers are definitely a group that are at risk of measles. It's also a disease where you can be infectious before you develop symptoms. And the early symptoms of measles can be very non-specific. Like Anne said, runny nose, a cough, sometimes it can give you conjunctivitis, fever. And then the rash, the typical rash, usually comes on about the 4th day of illness. And that's when people usually kind of cotton on to the fact that it's measles. But it also has a long incubation period. So between the time that you're exposed to measles and the time you develop symptoms is usually between 10 and 14 days. So a traveller can get it during their trip and then develop symptoms, a week or 2 after they come back. And so they may not even think about linking it to the trip that they took. In fact, when I was a child in the 1980s, there was only 1 vaccine dose in the schedule. And while 1 dose is effective, 2 doses is more effective in protecting against the disease. And so those people who only have 1 dose may have waning immunity or partial immunity. So really important to get that 2nd dose, the catch-up dose. And really the outbreaks that are happening worldwide are due to a combination of declining vaccination rates. We know during COVID there was massive disruption to immunisation programs, so a lot of countries fell behind in their childhood vaccinations. And also there's, just increasing globalisation, increasing travel, and really spread into under-immunised communities like we're seeing at the moment in the US.
I had my vaccines, in the 80s. So if I'm traveling now, is this something that I should be worried about getting a booster shot for, or getting it as a travel vaccine? Like, what's the guidance around that?
So we know that if you've had 2 vaccines, there's a good chance that you are protected. It's if you've had 1 vaccine that you're probably not protected. We don't routinely do serology, but serology often gets done for healthcare providers. So if you're a healthcare provider, if you're actually immune or not. The general public doesn't. So the vaccine we use is a live vaccine, live attenuated it's called. A combination of measles, mumps, rubella is what we use here in Canada. And the vaccine was introduced at different years around the world. In general, if you were born in the late 50s, likely you were exposed naturally to measles and you've got natural immunity. But even if you had measles many years ago, you may need to get vaccine to booster your immune response if you're going to be potentially exposed. So if you're a healthcare worker, if you're traveling internationally, or if you're at high risk. In the US, it was introduced in 1971, and it just depends, like I said, about which country you're from. In the late 60s, there was another vaccine that was available, which wasn't a live vaccine, but an inactivated vaccine that isn't or was not as good for the immune system. People who had that vaccine definitely would benefit from another vaccine if they're going to an area where there's a risk.
I'm not going to ask Albie how old he is.
You asked how long ago I was born. I won't tell you that, but I was, when I did my house job, we regularly saw children dying of measles on ward round in pediatrics every week, every day. But that's coming back, and that's really scary. When I started travel medicine, measles wasn't mentioned in travel. It was just not the phanogram. And then it started creeping in the last years. And that is because travelers are getting measles, but they're getting measles because large parts of the world that used to be well covered are no longer well covered because people have become complacent. So I'm cautious to use it because I'm not a real academic, but the reproductive number was bandied around a lot in COVID. And I've got a little gram that sticks in my head that says the reproductive number of measles is 18. Okay. It means one person with measles will give it to 18 other people that are non-immune. And because, we have our outbreaks of things regularly in Africa, one of the big outbreaks we had around about 2014, 2016 was Ebola. And people were hysterical about Ebola. But Ebola's reproductive number is 2. And then I know people became more and more clever, but when COVID started, it was like the reproductive number of COVID is 4. Now, if you think about how many people do you know that got COVID? Can you imagine if we're in an unvaccinated world, how many people are going to get measles? And how many people did you know that got COVID that died from it? Okay, so how many people are going to die from measles if they're unvaccinated? And this is just something that we're sitting in a world that has become totally complacent.
Yeah, Albie, you talk about the reproductive number, and I think that's right. Measles has a really high one. It's highly contagious. The other concept that's important here is the concept of herd immunity. So with measles, because it spreads from person to person, this concept of herd immunity, making sure a critical mass of the population is vaccinated, is really important to stop outbreaks. And one dose of the measles vaccine is about 93% effective at protecting against disease. 2 doses is 97% effective or more. And so you need a large proportion of the population to have had 2 doses. So we're talking 93 to 95% of the population to have had 2 doses or have had infection and be immune from infection to prevent outbreaks. And so that's a really high level of coverage that you need. And as soon as you drop below that level, you've got the conditions that are able for outbreaks to spread. And we know also that there are often pockets where a lot of people in a certain community are not vaccinated because they share certain ideas about vaccines, or they're hesitant about vaccines, or they're just in a really difficult political situation where the vaccines can't get to them and they don't have vaccine services. Those populations that are under-immunized are the most vulnerable to these outbreaks.
Yeah, Sarah, you make a good point.
I don't know the actual reproductive numbers for diphtheria and pertussis, the other so-called childhood diseases. But you mentioned just now, Sarah, that COVID disrupted childhood immunization programs. And then the WHO, UNICEF, etc., predicted that we're going to see a rise in childhood diseases, irrespective of people's ideas or beliefs or etc. It was just because practically kids didn't get vaccinated. And so I think what's so scary about what we're seeing happening with measles is we know that measles is really it's really the bugle player. Measles is happening, and we know that diphtheria and pertussis is going to happen. It's going to follow in the footsteps, because the same kids that are not vaccinated, or the same adults that are not vaccinated against measles, are not vaccinated against pertussis, diphtheria, and tetanus for that matter. And we already see it in South Africa, outbreaks of diphtheria and pertussis, which we haven't seen for years, and it's coming back. So we're really sitting on the brink of an abyss in terms of vaccine preventable diseases, and measles is just the showcase in a way, the warning sign.
Yeah, Albie, we've been seeing pertussis cases going up here in Canada, and definitely in Europe. They have actually been seeing cases of diphtheria in pockets of communities that are being under immunized because they're being exposed to maybe people who may have not been getting their vaccines for reasons because of migration or conflict, or even just because they choose not to get vaccinated. So that definitely is a big issue, and one of the reasons that we're seeing all these outbreaks starting to pop up now around the world.
So pertussis was responsible for one of my most memorable medivacs, 43-year-old Belgian guy working in Congo Brazzaville, who got medivaced one night with so-called concussion. And everybody thought at the time that he partied too much with the head office guys being there. But it ended up being a $60,000 medivac because he wasn't on insurance. When I saw him in hospital and started asking questions and saw the scabs on his arms, it was because he was having bouts of pertussis cough, and he coughed himself unconscious on more than one occasion. And on this occasion, he fell himself into a linear skull fracture, for which he had concussion and for which he had to be medevaced. So we had a vaccine preventable $60,000 medevac. And of course, he'd been vaccinated in childhood. He grew up in Belgium, had then been living in Australia, had a sister in South Africa, and was working in Africa. And people were saying, oh, he must have caught pertussis from the little kids in the village next to the mine. There was actually a pertussis outbreak in Australia at the time. So he brought pertussis from Australia all the way back to those innocent little kids in Africa.
Well, it's interesting, right? Because we're talking about primary vaccines, such as measles, that would be really accessible or potentially available in your primary series around the world, and something that we categorize in travel medicine as a routine vaccination, or something that you probably should have had as a base, before you come in for your what we call travel vaccines when you're kind of more destination specific. But I think an interesting example, Albie, and you could probably speak to this, is Mpox. So the Mpox outbreaks that we saw, or formerly known as monkeypox, which is a viral zoonotic disease, meaning that it jumped from animals to humans. And this, we saw huge outbreaks happen a few years ago, and there was a public health emergency of international concern call in regards to it. Now, Mpox is characterized by fever, headache, muscle aches, and a very distinctive rash that progresses through different stages, where it can look like poxes that eventually scab and fall off. And this is transmitted through close contact through individuals. But Albie, can you speak to kind of what happened with the Mpox outbreaks that occurred first in 2022 in travelers, which got international attention brought to it?
I think maybe I want to start off with what didn't happen with Mpox. For all the years that it had been ongoing in large parts of Africa, but in the Democratic Republic of Congo in particular, where it caused thousands of cases and hundreds of deaths for the last 20 years, and nobody paid any attention. It was just another disease out there in dark Africa, until it traveled and it spread into certain communities in the north, and it spread like wildfire amongst certain communities in large gatherings, and that's when it attracted attention from the world. And I sort of always grew up with the idea that we had smallpox, and of course we have to mention smallpox, which had been eradicated by a wonderful vaccine. But what has happened is that Mpox moved into this epidemiological vacuum that developed. So when I was a kid and got my smallpox vaccine, and when there were people living in areas of the Congo with smallpox, they either had natural immunity or they were vaccinated. And we stopped vaccinating against smallpox because smallpox had officially been eradicated in the 1980s. And so they stopped vaccinating everybody. But Mpox, which was already there, or obviously it was already there, that then saw the gap. And now we've got huge generations that have not been vaccinated against smallpox. And so they are clinically becoming ill with it. It is spread from rodents typically, some other mammals as well. Children play with them. Some people eat rodents. And that's how it gets into families and households. And that's how it's been spreading. And it only unfortunately attracted attention when it came to the developed world, in communities of men who have sex with men, in some other sex workers, and suddenly it attracted attention. And what I always understood is there's no vaccine against it. But guess what? The smallpox vaccine could be modulated when there was interest and when there was a scare. And so we've now got a vaccine that is extremely effective and available to well-to-do communities in the global north, but is still very, very hard to come by in Africa, where it's an ongoing disease. It's a sad story again of the haves and the have-nots. And in my own country, where I've been jumping up and down for the best part of 2 years saying, can we please get the Mpox vaccine in some way or another? The government proudly announced last week that we've got 10,000 doses that will be made available to vulnerable communities. And the first clinic that it will be available is a clinic in Cape Town only, that caters to a male community. And when a colleague went onto the website to see how can they get to this clinic to have the vaccine, it transpired that the clinic had been closed indefinitely because of the withdrawal of United States funding. So the only clinic where it's available, it's not available because the clinic's closed. So that's where we're standing with Mpox. We're still sitting with parts of the DRC that have not got access to, and it's not just in the DRC. Our most recent case was in a traveler that went to Uganda and picked it up there and spread it to 2 people in Johannesburg. Now, of course, there's a change. There's a genetic change in the virus, and that has attracted attention all over again.
Maybe an important point to make here is that Mpox, unlike measles, it's not highly transmissible. It needs close contact. So, you mainly see it transmitted in household settings where people have close contact with each other, or in intimate settings. So it can happen in anyone. It happens in families, and otherwise it's just the nature of the contact that you need to spread the disease is close contact. I think this is a disease that's spread across the world. It's been seeded by travellers. So I think that's a really important point to make.
The cases we've had that have, again, ended up in the press is in people who are seriously immune compromised for whatever reason, and those people become seriously ill and end up in hospital and sometimes die. But in most people, it can be a very mild disease. The diagnosis is either missed or the diagnosis is made, but it's of no big consequence, which sort of shadows what we see with another disease we're going to talk about, which is polio, where it very often spreads asymptomatically in the community with devastating consequences to certain individuals. And that's a pattern that we really see in many viral diseases. It can't be ignored because it simmers in the community. And unless you actively do something about it, it's not just going to go away. So you either vaccinate or you ignore it at your peril.
Well, it's interesting, right? Because the Mpox vaccine is not something that we routinely give in travel clinics, right? It's not something that is considered truly a travel vaccine. Although, obviously, we see that it got attention and the awareness was brought to the global eyes because of the outbreaks that happen because of travelers. But I think it's interesting because compared to routine vaccines where we would recommend everybody to vaccinate, for Mpox, we really, in the travel medicine world, we talk about really focusing on the highest risk groups. And what we recommend vaccine for Mpox would be, for example, men who have sex with men, or healthcare workers who are working in high-risk situations or with high-risk patients, or those who may be immunocompromised in those situations. And then again, for travelers, it would only really be for travelers going to regions where there may be outbreaks, or where they might have exposure to these Mpox cases because of activity or the endemic areas that they're going to. So it's interesting, right? Like, it's not typically talked about as a travel vaccine, despite the fact that it was kind of brought out by travelers.
And Aisha, I mean, some of that is due to vaccine supply issues. Albie talked about the situation in his country, in South Africa. Similarly, I guess in Australia, we have a limited number of doses. And so in our setting, those doses are controlled by the Public Health Department, and they set the criteria for who's eligible for the vaccine. And so really it's targeted towards the highest risk populations, both in terms of who's most at risk of being exposed, but also, as Albie pointed out, who's most at risk of developing severe disease and severe consequences from the disease. So that's, for instance, people living with HIV.
If we take it to the flip side and say that, the flu vaccine or influenza, which is available to everybody almost worldwide, but despite that, we're seeing probably the highest flu numbers that we've ever seen internationally this year and last year. How would you kind of respond to that?
Well, I mean, flu is one of the most common vaccine preventable diseases in travellers, if not the most common. It's a risk for all travellers. And while it's seasonal in some parts of the world, it can circulate year round in the tropics. And I think we're seeing, even in the places where it's typically seasonal, we see cases outside of the flu season increasingly more commonly. So, even if you're travelling outside of the flu season, to a country, there might be other travellers coming from their flu season, and travellers, when they come together, they come together on tours, they come together in cruise ships, they come together in large gatherings, and they can bring flu with them. So last week I saw a patient who had just returned from Japan, and Japan's in the northern hemisphere, so they're just at the end of their flu season now. And on her flight back, she started getting a runny nose and a cough, which developed into a fever. And several of her friends who she'd been traveling with were also sick. And when they came back, they got tested and they were all diagnosed with influenza A. Summer's just ended here in Australia, and our flu season is usually May to September. And she and all of her friends had the flu vaccine last season, but we usually get our flu vaccines in March, April. And so the highest protection from the vaccine is in the first 3 or 4 months after your dose. And so it's a good reminder for travellers that you can actually get a second dose of the flu vaccine if you're travelling in the opposite hemisphere during the flu season. And so perhaps if these travellers had, gotten a dose of the vaccine before they travelled, they could have avoided getting the flu, or at least gotten a less severe form.
Yeah, it's very tricky with flu, isn't it? Because the virus itself is kind of sneaky. There's 3 different viruses. We really vaccinate against influenza A and B, which are the most important ones, and different types of those. But the vaccine's not 100%, and the virus changes. So, the Southern Hemisphere often knows before we do about, what's happening with respect to which viruses are circulating. But you can be, despite all the efforts of public health, WHO, other groups, to make the best guess for the next flu season, there's still a potential for error, right? So if they have an H1N1 influenza A strain in the vaccine, it may not be a perfect match. So it may not work 100%, even if you're almost covered for that particular virus. So it's very tough. It's tough to have the right vaccine. And then it's hard for travelers and others to understand, hey, I was vaccinated. Why did I get flu? So as you said, Sarah, sometimes it's because it's too late, or it's a long time since I got vaccinated. Sometimes it's because we just didn't quite get it right when we, tried to figure out what's the best combination vaccine to use.
And the vaccines we use usually have 3 or 4 strains of the flu virus in them. So we call them trivalent or quadrivalent. That just means 3 or 4. It's usually 2 strains of flu A and 2 strains of flu B if it's a quadrivalent vaccine. And like you said, and there can be more than 3 or 4 strains of flu circulating. So if the vaccine doesn't include the one that's circulating, then there can be a gap, a mismatch in what's circulating and what the vaccine protects against. But the flu vaccine is really important in terms of minimising the severity of the disease, and it does a very good job at reducing hospitalisations against flu, even if it doesn't protect you against getting flu disease.
I think that's very important for individuals that are at higher risk. So young children, pregnant women, older individuals, or individuals with underlying respiratory illness who may not do well if they get something like influenza. And we know that influenza can put you at higher risk for a secondary bacterial infection, where if you don't have good lungs to start with, you might get critically ill from. So I think there's a lot of potential downstream benefits of the flu vaccine as well.
And I think from the numbers coming back that we've seen that influenza, in fact, is the most common vaccine preventable disease in travelers, right? And the influenza vaccine is not considered to be a travel vaccine. This has been I've been advocating, and it's been mission to make influenza a travel vaccine for that reason, that travelers may be visiting destinations outside of the flu season where the vaccine is actually available. So just another example that every vaccine is a travel vaccine, and I think this is a very great example of that. Albie, what about in your parts of the world? How does that vary for you there in regards to influenza and travelers, or what do you recommend?
Well, as a country, we're totally lousy when it comes with seasonal influenza vaccine coverage. We're just preparing like Australia to go into the winter season, and we're waiting for our trivalent vaccine to come, which is a nice little story because WHO is saying we don't need quadrivalent for the second season in a row because COVID eradicated the Yamagata strain. And that is, again, we think we live in the real world and we're fighting wars on all fronts. But in the virus world, there are all these interesting things happening, like one virus pushes out another virus. So we have people that are ardent believers in the flu vaccine, and I've had mine since I was 14 years old. So that's a long, long time ago, because we were not allowed to take part in the annual school play or operetta if you didn't have your flu vaccine, because the play was staged in May, and that was sort of peak flu season. So no vaccine, no play. And I've always had mine, and I've never had, touch wood, flu. However, we work with a lot of people that work in tropical Africa, and that's one of the things we preach is, how does the flu virus get from the northern hemisphere to the southern hemisphere? It travels through the tropics. So there's always flu virus in circulation in the tropics. So it's never wrong to give the mine worker that's going to work on a mine in the Congo his flu vaccine. Early in the season, late in the season, we don't have flu vaccine available year round, and we don't have access to the northern hemisphere vaccine, and we don't know which virus is in circulation in the tropics. You guys from Australia and Canada, I'm sitting with hordes of your compatriots in the Congo working on the mines. Don't forget them for Mpox vaccine. Limited medical facilities, closely working with villages. The mine worker in the tunnel next to you has got a kid that was playing with a rodent yesterday at home. And if he hasn't got severe disease, which he's likely not to have, he's rubbing off his vesicles on you. So it is not to say it's only for certain groups, wink, 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 that should get the vaccine. Your mine worker is exposed when he's going to a highly endemic area with limited medical facilities and actual close contact with the community. It's all beautifully intertwined, which is why travel medicine is so exciting.
But Albie, you had mentioned polio earlier. Tell me a little bit about how you would kind of approach polio as a travel vaccine, because it's not something I typically imagine to be something that we talk about in our travel consults very often.
So COVID was declared, you named it something else just now, but we talk about a public health emergency of international concern. So COVID was a fake, Ebola at some stage was a fake, but which disease is still a fake and has been since 2014? Well, we're talking about polio. So it's scary again to think that polio has been a public health emergency of international concern for the last 10 years, and we hardly pay any attention to it. You don't hear anybody talking about it in public health forums, and we don't mention it when we talk about travel vaccines. Now, we know that the only two countries in the world where we still got wild polio virus circulating is sadly Afghanistan and Pakistan. But we've seen a huge resurgence of circulating vaccine-derived polio because we haven't got adequate coverage. And we talked about measles just now, where you need 95% coverage in your population to get herd immunity. Well, you need the same sort of numbers to get herd immunity against polio. Now, we've eradicated one of the polio strains, but we're sitting with the other two. And again, we're sitting with two worlds. On the one side, we've got large parts of the world, I would say the majority, bit of a thumbsuck, where we're still using live oral polio vaccine to vaccinate because it provides better herd immunity than the injectable killed vaccine. In parts of the world where polio has been eradicated, like the United States, like Canada, I think like Australia, we're using injectable polio vaccine, which is a killed vaccine that has got absolutely no risk of causing disease. But the oral live polio vaccine can cause disease and does cause disease. And we're seeing a huge rise in this. So the WHO declared it a public health emergency of international concern in 2014 and have made certain stipulations that if you travel from a country where we've got either live wild polio virus circulating, we know that's just Afghanistan or Pakistan, or where there is circulating vaccine-derived polio, all adult travelers, all people should be fully vaccinated, have a primary series of polio vaccine. And adult travelers should receive a booster before they leave that country. And if you're a traveler and you go to that country for longer than 4 weeks, I'm not sure where the 4-week thing comes in, but then you should also show proof on your international certificate of vaccination and prophylaxis, your yellow card, very often confused with the yellow fever card, that you've been vaccinated or boosted against polio. And that is not happening. I heard of one traveler recently that said they were asked in Egypt in transit whether they could show proof of polio vaccination, but nobody else is doing that. So polio is happily spreading out there. They should get a polio booster by default, an injectable killed polio vaccine, which can do absolutely no harm, but does a little drop in the public health sea to help us stop this dreadful disease that killed and maimed millions of people through the ages, and very recently still had 350,000 people on ventilators all over the world.
Yeah, in Canada, there's still people who sleep in iron lungs, right?
Exactly.
Even this many years later,
Yeah.
right? Who were infected as children, and
Yeah.
they're in their 60s and 70s. It's horrendous.
It was recently in the news about a lawyer that passed away in the United States that was, I think, was the longest surviving polio victim that spent his entire life and his legal career in an iron lung. I had a cousin that wanted to be a ballet dancer, but she had polio and survived it and had one bad leg because of that. It's a dreadful disease that the developed world is not seeing and have become complacent about, just like measles.
I think polio as well is a great example of how COVID set us back. Because before the COVID pandemic, we were close to polio elimination. And now we're further away than we were 10, 15 years ago. During the pandemic, there were resources and staff redirected to fight COVID, and routine immunisation services were reduced. Lockdown, travel restrictions made it difficult for health workers to reach children and to get vaccination campaigns out there. And that meant that millions of people missed out on their polio vaccines. And I think as Albie kind of touched on, there are two different types of polio vaccines available: the injectable polio vaccine, or IPV, which is what we use in our country, I think, most of your countries, and the oral polio vaccine, or the OPV. And OPV, the oral polio vaccine, is widely used because it's easy to administer. So it's in a drop formulation, so you don't need a health worker who's trained in vaccination to give it. But if vaccination rates are low and sanitation is poor, the harmless strain of the vaccine that's in the oral polio vaccine can circulate in the environment, and it can revert into a form that causes paralytic polio, so that causes the disease, and that's called vaccine-derived circulating poliovirus. And so, as Albie mentioned, many high-income countries have switched from the oral to the injectable form to avoid that risk. And the inactivated polio vaccine causes long-term protection, but it does need boosters in adults. Again, this is a disease where global vaccination efforts are critical to stop polio circulating. So just like for measles, we need to maintain high coverage against polio across our country and other countries to prevent this disease from spreading.
And we have seen cases spread from international travel as well. There are cases linked to cross-border travel between Pakistan and Afghanistan. We've seen, there was one case that was in the news in November, I believe, a little girl from Central Java in Indonesia who had traveled to an area, a pocket where there was a polio outbreak in Madura Island. And even in Europe, actually, they've been doing some wastewater testing in multiple European cities, and they've found poliovirus in London and Barcelona, in Warsaw, and Munich, in Cologne, in Hamburg, and Leeds. And so this is likely that it was introduced maybe from international travelers who may have come from these polio affected areas. And Albie, you say there's no polio in the United States, but they actually did have a confirmed case even of paralytic polio in New York City a few years back that was actually introduced and brought in from an international traveler and introduced to an under-immunized community in New York City there. So, this risk of these diseases, especially spreading through travelers, is definitely there. And I think it's a situation that we're seeing as travelers being implicated in these outbreaks in these communities that are basically either unvaccinated or under-vaccinated.
I think the other thing that's concerning about polio is, you can spread it silently for weeks, and many people don't get any symptoms, or they have very little symptoms. And it's only the tip of the iceberg that we see of people who actually get paralytic polio or any devastating consequences of the disease. So if I have no symptoms, I could potentially happily spread that. And especially we're talking about vaccine derived. So if I'm in a country where, if I go to visit a country where I'm not immune to polio and I pick up that vaccine strain, which is mutated, I can bring it home and potentially spread it. We're lucky here because we do have good sanitation. So it does vastly decrease that from happening, but it can still spread at home once you've finished your travel.
Just to mention, I was thinking now, in Afrikaans, we talk about kinderverlamming. I'm not sure whether it's the same in English. Childhood paralysis, is that another word? Is that a common word for polio? But in fact,
Yes.
it doesn't just affect children. Adults can contract polio if they're not adequately immunized and can suffer exactly the same consequences, losing the use of a limb. A lot of these diseases we think of as childhood diseases, and well, maybe I haven't been vaccinated, but I didn't get chickenpox. But a lot of these childhood diseases are a lot worse and more life-threatening if you contract them as an adult, such as chickenpox. So, even if you come to the travel clinic for a yellow fever vaccine, which is what we see all the time, check on the childhood vaccines and the childhood vaccination and or natural immunity, and use the opportunity to say, have you had a chickenpox vaccine? That's an opportunity to boost public health.
We always talk about the routine vaccines and the travel medicine vaccines. I think, what we're talking about today is the merge of those things, because travel medicine consult has always been an opportunity to review those other vaccines, but there's more and more need to actually address them and perhaps get a booster or get the vaccine for the first time before you travel.
Absolutely. I think we need to change our approach and truly consider that every vaccine really is a travel vaccine. A vaccination is just so simple but effective to reduce the risk in our travelers, but also in vulnerable populations, to protect them and to prevent also disruptions in our travel plans. And I think we are seeing now with the recent rise in outbreaks that it's truly, a lot of it has been directly linked to international travel, which again really reinforces the importance of vaccination for everybody.
And Aisha, it's not just if you're traveling to low and middle income countries that you need to worry about vaccines. I think we need to think about vaccinating travelers regardless of their destination, because many of the diseases we talked about today are circulating in high income countries too. So, whether you're heading to Bali, Barcelona, or Boston, the diseases of the world don't respect borders and they can circulate anywhere. But vaccination can build the protection that you need.
Certainly most people wouldn't go to a travel clinic if they're going to Boston from anywhere. So it's important to plug into public health clinics and primary care practitioners to make sure your routine vaccines are up to date, no matter where you're traveling.
Yeah, so really encouraging vaccination as a essential for travel, just like you check to make sure you've got your passport in your purse and to make sure you have your travel insurance or whatnot. But I think looking at it in that perspective really will help prevent illness and protect our communities and really help keep our global world a safer place for everybody. So thank you very much to our incredible team of experts today, Dr. Anne McCarthy, Dr. Albie de Frey, Dr. Sarah McGuinness, for joining us on this very timely episode of Travel Unraveled. Very excited that we've kicked off our second season of the podcast, and I can't wait for you to see what we've got in store for you this year. As always, we've included all the links that we've mentioned on today's episode in the podcast description. And if you do like this episode, please don't forget to subscribe and let us know your thoughts. We love hearing from our listeners. So we hope you enjoyed this episode, and we'll see you next time. Safe travels.
So that's a wrap for this episode. Thank you to our sponsor, the International Association for Medical Assistance to Travelers, located on the web at iamat.org. Don't forget to follow Travel Unravelled on Spotify and on Apple Podcasts or on your favorite podcast platform. We'll post fun clips and extra resources on the ISTM website located at learning.istm.org/podcast. We're also on Facebook, LinkedIn, X, and Instagram at _ISTM_. Travel Unravelled is brought to you by the International Society of Travel Medicine. Finally, and thankfully, Travel Unravelled is produced by Ghost Bureau out of Toronto at ghostbureau.com.
Please remember that the information presented in this podcast is intended for educational and informational purposes only. It should not be considered medical advice, nor is it intended to replace consultation with a qualified healthcare professional. The views expressed by the host and guests of this podcast are their own and do not necessarily reflect the opinions or policies of the ISTM or any medical or other health professionals, hospitals, clinics, or healthcare facilities. While we strive to provide accurate and up-to-date information, the medical field is constantly evolving, and there may be new findings or developments not included in our content. We encourage our listeners to consult with their healthcare providers for any medical concerns or before starting any new treatment. Neither the ISTM nor any of its affiliates, sponsors, producers, hosts, or guests are liable for any direct, incidental, consequential, indirect, or punitive damages arising out of access to, use of, or inability to use the content of this podcast, or any errors or omissions in the content hereof. By listening to this podcast, you agree not to use this information as a substitute for, nor does it replace professional, medical advice, diagnosis, or treatment. Always consult with your healthcare providers for guidance appropriate to your specific health situation. Thank you for listening to Travel Unravelled. We are committed to sharing knowledge and fostering discussion in the pursuit of better health and well-being.